Hello there, it's Dr. Verlage again with our monthly presentation. Today's presentation is titled Basics of Medication Management for Perinatal Depression. For the purposes of today's conversation and presentation, we're going to focus on the family of medications, the most commonly used family of medications, the SSRIs, serotonin reuptake inhibitors, just because there's multiple families of medications, considerations for each family for different psychiatric conditions. So just in the interest of time and in the kind of context of what's used more often, we'll keep the presentation today talking about the SSRIs. But a lot of these principles will apply to any family of medications. And when we're talking about risks and benefits, how we need to be thinking about it during pregnancy. So I think this is a good slide to start with, and I stole this slide from a Mass General Hospital presentation that I watched, which is comparing the real risk of malformations when using medications versus the perceived risk. So the left-hand side took data from is demonstrating data from a toxicology paper that talks about the risks of malformations. So any pregnancy has a risk of 2 to 4% of having a malformation in the baby with any pregnancy, with any exposures, right? So they break down what percentage of the risks are from different causes. So 9% of those 2 to 4% of newborns that were born with malformations were due to medical conditions in the mom. A quarter, or 20 to 25%, were due to some kind of genetic etiology. 65% were thought to be of unknown origin, but not attributed to these other more specifically listed categories. And fewer than 1% were thought to be due to drug exposures. So 1% of the 1% of the 2 to 4% of newborns with malformations were due to medication exposures, right? This is very low, much lower than what the perceived risk of medication exposures causing malformations. So the perceived risk, they asked women in this paper, what do you believe, what are the risks, what's the risk of a malformation because you take a medication? We're talking medications in general, by the way, not just psychiatric medications, but they believe the risk of a malformation was 24%. Which is very different than the 1% of the 2 to 4% who actually have a problem. I mean, that chasm is quite large. So, I think keeping this in mind as we walk through this presentation and think about medication risks is important. Now, this is not to take away from the fact that there are medications that can cause malformations, and there are psychiatric medications that cause malformations. Depakote is the main one that we avoid. I avoid in women of childbearing age in general, unless, say, they've had a hysterectomy and can't get pregnant. But outside of that, and that, historically there have been medications we didn't know cause malformations, and they did. But if we put this in the context of all the medications we use all the time, the absolute risk is very low. We don't want to dismiss the importance of making sure that we're not causing problems. But again, the absolute risk is quite low, according to this toxicology report. So, we'll talk about this in a little more detail later in the presentation, but it is not as simple as you take a medication and expose your baby, or you suck it up and that's what's best for your baby. That is not how we think about it. Moms who feel good have good, and that's helps baby grow best, and baby does best when mom feels good, right? So there are risks associated with taking a medication. There are risks with not treating. So neither of these options are risk-free. And again, we're going to balance risk and benefit of each, in every case, of what we want to do and what we think is going to be best for both mom and baby when we make our recommendations. And SSRIs, of all the families of medications that we have for use in pregnancy, SSRIs are the best studied family of medications. Fortunately, they're also the most used, and I'm sure the fact that they're the best studies and the most used is not a coincidence, but helpful. So, I've mentioned this in different presentations, but very briefly, perinatal depression affects mom, child, and family negatively. So we know that it can affect the health of mom on multiple levels, higher risks for diabetes and preeclampsia, substance use, suicide risks, and others. When we come to the outcomes of perinatal depression on baby, we see studies that confirm low birth weight, preterm delivery, cognitive delays later in life, behavioral problems later in life. So this is the risk of not treating slide for perinatal depression and anxiety. Now, this is not to say that any whiff of depression we need to jump in with medications. There are candidates who are struggling with depression who would be good to start with therapy and then reassess, right? So who would be, and when we're counseling patients, kind of triaging who would be a candidate to maybe not start medications right away and focus on therapy and other interventions. Who would those people be? Mild depression. So I like to classify severity on functioning. So mom's still very functional, taking care of herself, able to go to work if she's working, or take care of kids if she's doing that, get out of bed, take care of her hygiene, all of that. If that is going well, that's a point in the favor of offering the option of not medication. No suicidal ideation, starting or already being engaged in psychotherapy. If her history shows that she's responded to therapy in the past, that would be a point in that favor. And if it's her strong preference to avoid medications, then yes, and if she meets the above. Now, the phrase at the bottom of that, at the end of the day, this is mom's decision, and I think an important piece here is to be collaborative with mother and meet her where she's at, and even if she's not going to start a medication, I want to meet with her and talk with her to be able to answer those questions, reassure her, and get her started when she is ready. So that's just a side note. But when should we maybe encourage more strongly for them to start a medication? If the severity is more moderate to severe, if they're having suicidal ideation, if they are finding it difficult to care for themselves, for their baby, and for their kids. Any psychotic symptoms, we've brought this up in other lectures, but any psychotic symptoms in a new mom in the newborn phase, or I would say, yes, needs to go to the hospital. It is an emergency and they need to be treated with close supervision. If they have a history of very severe depressive episodes, or if they have comorbid anxiety, those might be ones that we might encourage more strongly to start medication. So when it comes to how we practice medicine, the best type of data we can use to guide us in terms of treatment are what we call randomized controlled trials. You see that on this pyramid, it's the orange one. And above that, systematic reviews, which takes all the randomized controlled trials that have been done and combines them together to get more data. And what is a randomized controlled trial? You have two groups. One group gets some kind of intervention, the other group does not and gets a placebo. And then you see what's the good and what's the bad that came out of that intervention compared to the control group, right? That's the best kind of data that we can get. Can't do that for pregnant women. You can't say, hey, let's give you this and let's see if it causes a problem in your baby compared to the other group. So what are we left with are these kind of lower levels of data, mostly pools of data, people who had to be on medications during pregnancy. We see how things went and we put their data into databases, and we try to, again, pull things together to see if we see any trends that are concerning or not concerning. It's already not the best kind of data, but we do what we can, and the bigger the pool of data, the more reassured we're going to be overall. I wanted to also bring up that there was a shift that was a decade ago now, but still used, and there's still some confusion. When we talked about risks of medications and their safety in pregnancy, we used to use a letter system, A, B, C, D, X, and NA, where A was, the best, safest in pregnancy, and you go down from there. What happened is the category system was misleading at times, how much they relied on animal data, how much, a lack of data could actually increase their category. And so it wasn't a well-designed system. And so what happened was they transitioned to the current system, which is more of a narrative of what we know and what we don't know, instead of these kind of very simplistic categories that we used to have. So that's the more recent system that we have. So if you ever hear somebody using the letter system, just know that it's outdated, and you should probably be looking at sources that use the narrative approach. So that's just as we talk about these risks, an important note when you're looking at data and when you're talking about these things. So let's say you are a mom and you're on Prozac and you are pregnant now, you become pregnant and you Google, can I use Prozac in pregnancy? What is going to pop up? Lots of different stuff. And a lot of times the kind of algorithm is going to pick to show you things that maybe that are misleading. So here's an example, sites of how Prozac will cause birth defects. This study is, linked to heart issues, what have you. These are individual studies that you can find and that were done, but not the pools that we use. There are many, many individual studies that showed something that was an issue that were later on discredited with more studies that were done, and when we started pooling together this data. So, and again, unfortunately, those are less exciting findings, and the algorithm doesn't show them as much, and so when you Google things, it's going to show you those little studies that were just proven later. So that's why it's so important, which at the end of this presentation, I'll give you some recommendations for websites of where to send patients to look for the pools and the narratives of what we have found for medications when they're trying to pick what they want to do. To add to this problem, I've complained at the last lecture that there was recently an FDA panel presentation. Recently as in like a month or two ago. Here I took a screenshot of when I went to go watch it. Don't you love that it's mostly men? Where what they did in their expert panel was to pick those smaller studies that were concerning and say that SSRIs are not safe for use in pregnancy and we push them too much. And I wanted to watch it so that I could be prepared to talk to patients about it. I think I got through 15 minutes. You can see it's a 2-hour-long presentation, and it's very hard to watch the language that they use, the studies that they show, that they choose to show, and knowing the damage that it does, the misinformation they are sharing to a very vulnerable population. I spend a lot of time talking to moms and explaining to them that they are taking care of their babies by taking medications. And I do not say that lightly, nor does any other perinatal psychiatrist. And it's awful to think how damaging this kind of stuff is, and it's not prepared responsibly. Anyways, So since that came out, these are just some of the organizations that have come out with statements stating concerns about that misinformation, or blatantly saying that what was said in that presentation was misinformation. And these aren't just little nobody groups. These are the heavy hitters in our field. So the American College of Obstetrics and Gynecologists, aka ACOG, Society for Maternal Fetal Medicine, American Psychiatric Association, Postpartum Support International, on and on and on. So anybody with any leverage and any, respect in the field has come out, trying to counter the damage that's been done, but cat's out of the bag, and it's very frustrating as a field to watch something like this. And so important that we're doing things like this to help people, know what to say if this comes up in a conversation with a patient. So, what are the things you're going to say with some of those concerning things that they brought up in that presentation or otherwise? When it comes to the absolute risk of birth defects when antidepressants are taken in the first trimester, so first trimester is when all the organs are forming, highest risk of malformations in general. Pools of data, reassuring. Any of these blips of small studies that show something, it's inconsistent and largely disproven with larger pools of data. Paxil has been the most controversial. In an earlier study, they did show some issues. Prozac has also been controversial at some point, but really any SSRI, any older SSRI has enough data for us to comfortably use it. The other thing is, if you say, go for the one that has the most data, which is Zoloft, Zoloft may not work for the mom. So mom will continue to be depressed, and you'll keep switching the medications, exposing baby to numbers of medicines instead of just using what works. Things like Prozac and Paxil that have the green light of use. Generally, as a field, we like to continue mom on what works as long as we have a general green light. The newer antidepressants, things like Trintellix and Vibrid, they're so new that we don't have pools of data for them. So if I were to pick something new for a patient, I probably wouldn't pick that first. But if mom is on one of those, they've usually tried a bunch of stuff. And, these pools of data come from moms who had to be on medications during pregnancy. So even then, other medications in that family work relatively well. So even with the newer ones, there are exceptions where I think it's absolutely appropriate to continue them. But, so the absolute, when I say absolute risk also, this is a side note, there's absolute and relative risk. Relative risk is, say, lithium causes a 3-fold increase in heart abnormalities in a baby. That sounds really scary. When you look at the absolute risk, we're talking like 0.1% to 0.4%, right? That means that 99.5% of moms who take lithium are not going to have any issues, right? So there's the language we use saying using the percent difference versus the 10-fold increase, 3-fold increase is going to help moms understand the level of risk, the overall level of risk. So anyways, absolute risk of birth defects with antidepressants, very small and largely disproven whenever it did show that there was an issue. Then one of the popular things to pop up if you do a Google search on antidepressants is persistent pulmonary hypertension. This was a study that was done over 30 years ago that showed a 1 to 2 per 1,000 births with this issue went up to 3 to 4 in 1,000 births. Again, we're talking very, very low absolute risks. In that study, and even after that study, it's been just the small absolute risk was has been largely disproven. So that's one that might come up. Now, something that does, it's, something that has been consistent and shown that can happen with antidepressants is this transient neonatal symptom. So when baby's born and no longer receiving, some level of exposure of antidepressants, they can go through a little bit of a discontinuation syndrome as it comes out of their body. Note that we don't call it withdrawal. We reserve that term for, say, babies who are exposed to opioids, things like heroin, things like benzodiazepines like Ativan. If they're exposed to high levels daily of those things and then they're born, they do need to be, say, monitored closely. There are some poor outcomes that come with that with baby. We're not talking about that. We're talking about a mild discontinuation syndrome that happens in up to, so not even, 30% of newborns who have exposure to antidepressants. It manifests as fussiness and difficulty latching in the first 2 to 3 days. So, versus the benefit of mom, feeling stable and well during pregnancy, we very much encourage, moms to continue and take medications, because compared to the risk of this, thing that can happen to newborns. Now at one point we thought that maybe tapering mom off of the medication before baby's born would be helpful, but we do not recommend that. And it's that benefit versus risk is still not worth it. So we also want medication on board to protect mom after baby's born when she's going to be at high risk for postpartum depression. So they've done a number of studies looking at babies become kids, so kind of the long-term effects on children if they were exposed to antidepressants during pregnancy and breastfeeding, and we do not see any neurobehavioral effects on children long-term. Coming back to this conversation of, there is no such a thing as any risk. There is no such a thing as no exposure. You're exposing baby to medicines, or you're exposing baby to the effects of depression and anxiety on the pregnancy. So, using the right language of encouraging mom and not making her feel, forced into any decision, but helping her understand that, her taking medications to feel stable is not putting herself above the needs of her baby. Taking care of herself how she feels comfortable is what's best for her baby. So instead of saying baby feels bad when you feel bad, it's baby feels good when you feel good, right? So it can be a tough conversation to say there's exposure to baby either way. Sharing these numbers with her, these risks with her, and which is all a lot of reassuring information about medications, is an important part of the conversation. When it comes to breastfeeding, we generally think of exposure during pregnancy as being more than during breastfeeding in general. We also know postpartum is a real time of risk. So in general, we don't have as many pools of data as we would like in breastfeeding. We don't have enough data in pregnancy, but we have even less data in breastfeeding. But generally speaking, the data that we have in breastfeeding is very reassuring and is something that we strongly encourage moms to continue in the postpartum period. So, where do we send patients to get good information? My favorite website is mothertobaby.org. What they do is they have this tab on the top called, I think it's information, and then you're looking for fact sheets, and then you can put in any medication, and it's going to give you that narrative, a narrative in a very digestible way of use in fertility, of use in early pregnancy, for use in later pregnancy, for use in breastfeeding, of a small segment that summarizes the data that we have and the overall recommendations. So very digestible, very up to date. This is where I would go myself and patients and send patients to if they want to read about what they're taking. If they want something a little more in depth, the leaders of our field is womensmentalhealth.org. They will have articles on specific medications or specific families of medications that will actually summarize these studies that are talked about. So it's a little more comprehensive than, say, mothertobaby.org. But for you guys or for patients who want a little more in depth about where those recommendations are coming from, this is a great resource. And again, that's kept very up to date with new data. This is also where I would go for patients who, say, watch that FDA panel and are concerned. They came out with a really well put together summary sheet of what patients need to know, basically summarizing what's in this presentation today, again, in a very digestible way, and specifically addressing some of the things that misinformation that was brought up in the FDA panel. So an information sheet for those patients who maybe want a little bit more, want to understand a little bit more. They have a great sheet, and it's called SSRIs in Pregnancy, What Patients Need to Know. It's at the bottom of that slide. But yes, great resource. Even just reading new articles that come up is a way to stay updated in the field. So if you have any questions, we're going to have a discussion on Wednesday, so I will be there, and please bring your questions to those. But otherwise, I'll wrap up today's presentation, and yeah, I'll see some of you guys on Wednesday. Have a great day.